Thank you. So yes, my name is Phil Davies. I work at the CCG, part of the commissioning team, but work with primary care as well. And I think just at the outset, it's worth saying, obviously in Hull, we were delighted to be chosen as a pilot site for the lung health check. As you'll see, some of our data is a challenge for us in terms of smoking and lung cancer. So when we had the opportunity to develop the programme, we really wanted to embrace it, work with colleagues, and I think, as hopefully you'll see by the end, it is very much a collaboration. It's about public health, working with commissioning, working with the Cancer Alliance, who obviously were the fulcrum of it all, but working with obviously the main acute trust, Hull University Hospitals Trust. So it is very much everyone working together. So what I'm presenting here is no way saying this is what the CCG's done, it's but how we've all worked collaboratively together. Just picking up to the point around deprivation, Hull is, I think it's the third most deprived local authority in the country, so no big surprise in terms of smoking rates and associated lung cancers. So I've got a bit of data just to sort of set a bit of context for you. So it's estimated in Hull at the moment there's about 45,000 adults out of 260,000 who are current smokers. So our smoking rates are falling, but we're still at about 25% of the population is smoking, aged over 18. We did have some wards, I don't think we still do, but in the not too distant past, we did have some wards where it was the norm for adults to smoke. Literally over 50% of adults in some of our wards in the more deprived parts of the city, unsurprisingly, were smokers. So well above the national rate. But that, as we'll see, does hide quite a bit of variation across the city. So smoking rates very much correlated with deprivation. And again, I think Stuart mentioned, didn't he, that whilst there's 25% of the population, adult population, are current smokers, there's a large number of previous smokers, ex-smokers, and the programme's targeted both at current and ex-smokers. So some of this data is just from the public health team do a health and lifestyle survey. So 24.9% overall smoking on the far left there. Males and females, male rates slightly higher than female. Age breakdown. I guess the interesting ones though perhaps are the three little charts to the right. So the middle chart looks at the status of people, whether they're working, student, etc. And as you can see there, particularly those last two columns, unemployed or not allowed to work, 45% currently smoking, and long-term sick or disabled, 48%. So huge numbers, or huge proportions within those particular groups. That really emphasises the need to really target and understand your communities, who you really want to engage with the programme. Next chart on the right just looks at deprivation, so smoking rates by quintiles of deprivation. Very clear gradient there. You could almost draw a straight line through it. So even our least deprived quintile, or fifth of our population, is only just marginally under the national rate, whereas the most deprived quintile is up at 35% smoking rate, more than double the national rate. Then finally, there's a chart there that identifies single people and lone parents. Again, two groups with very high smoking prevalence rates of over 38%. So really key, I think, is understanding your population, where the needs are, where you need to particularly have a focus. Got just a couple of slides just on lung cancer in Hull. So the dotted lines are the national figures, blue for males, orange for females, whereas the solid lines are the equivalents for Hull. So again, the orange solid line is Hull females, blue solid line Hull males. So you can clearly see a huge gap in terms of lung cancer incidence between Hull and the rest of the country. And particularly in the sort of last 10 years or so, until very more recently, cancer rates were increasing in the both males and females in the city. So this just really shows the gap, and I guess shows that the gap hasn't really reduced to any extent over the last 20 years. The gap at the far left of the chart is not hugely different to the gap at the far right. And then when we look at how many people this is, so in Hull it's about 65% higher incidence for men than the national average. So 145 people versus about 88 people, so 65% higher. For women, 83% higher, so about 123 people versus 67 people. And in some of our wards, as I say, the actual lung cancer rate is more than double the national average. And that obviously, unsurprisingly, feeds through to mortality, so significantly higher rates of mortality for men and women, and hence we were really, as I say, delighted as a health community to be part of the programme. What we did at the outset was an equality impact assessment, really important. If you're going to develop a service, you've got to understand the people, motivations, etc., who it's targeted at. It's great a group of us sitting in a room designing a service, but you absolutely need to go out and engage with your communities, understand the issues that affecting them, what would facilitate them engaging, what would encourage them to engage and participate. So we had a number of discussion groups and stakeholder events, and I think other colleagues will probably talk about that a bit more. That guided the literature we used, the sites we wanted to explore in terms of delivery of the service in the community, and the highlighted, I guess, access to interpretation. We have, in certain areas, large numbers of non-English speaking population, so we needed to understand, be able to engage with them, offer double appointments. Did some modelling. This was primarily the Cancer Alliance, so this was just a bit of a feel for, okay, if we're going to embark on this programme, what are some of the numbers we're going to have to deal with in terms of appointments, lung health checks performed, CT scans, etc. So this was some of our early modelling. Important thing, I think, to identify, the last two, is that this programme will identify a lot of other things as well as lung cancer. And that, I think, as the programme's gone on, that's probably become more and more apparent. And I'm sure Dr. Belush, one of our GPs, will pick that up later. A lot of other findings other than lung cancer that need further action. So we obviously had to develop a business case to get the programme up and running. We had a lung health check allocation of resource that we received centrally, and that covers a number of areas which I've listed there. But it's important that there's a whole lot of other impacts of delivering the lung health check, so you have to understand what those impacts are from a commissioning point of view. Particularly, obviously, for the hospital trust, there's lots of other pathways that people potentially are going to go on to, not just a lung cancer pathway. So there's various other funding that is needed to support the programme, both from the CCG but also from specialist commissioning where necessary. So as I say, in terms of that business case and getting all the resource in place, you need to understand all of the potential impacts of delivering this programme. So lung cancer, 2-week waits, but lots of the other clinical anomalies that are found. So there'll be other cancers. We've had other cancers found. There's an impact there. Significant numbers of other respiratory disease that hasn't previously been diagnosed, as well as other cardiac conditions, coronary calcification. So it's important that all the other services that need to follow up and pick up those issues are part of your planning, part of your understanding. Is it 1 minute left? Yeah. And make it as easy as possible for those patients to access those services. Inevitably, particularly for respiratory, spirometry delivery has been a big challenge because out in primary care, I think there's minimal spirometry and has been for a long time, so there's a big backlog potentially of spirometry. This is just a simple table to try and demonstrate the various aspects in terms of the business case that the CCG board ultimately approved and where the resources come from. So the lung health check provides some resource, but you do need to understand at a locality what the other aspects, and you need to be thinking about the implications and where the resource there may come from. So finally, I think, key messages, there we go. So I think the key things I'd say from a commissioning point of view, very much about that public engagement and communication. So you've really got to get underneath your population that you're aiming at and understand their motivations. Engaging with all key stakeholders, primary care obviously are key to this. That's where your source of your invites are from. Then there's an impact going back. When people have got a query when they've had a letter, it's often the primary care they may ring or go into previously. Understand the full impact of delivery of the service, so all the potential pathways and services that will be impacted. And very much it's been around working as I'd like to think, a partnership closely between the Alliance, the CCG and the Acute Trust. So it's not, no one organisation can deliver this on its own. It's about all of us working together collaboratively, but very much with that clear focus and aim around making a substantial impact on lung cancer incidence and mortality in the city. So I think that's all I was wanting to say. But I guess partnership's the key thing. It's all about partnership and working collaboratively.